everyone, and welcome. Today we're going to be talking about the management of complications following oral surgery. This is a three-part lecture, so today we'll be doing part A. So what is a complication? A complication is basically an additional problem that arises during or following a procedure that you've provided for your patient. Now immediately, most of our minds would think of something like an infection or dry socket or bleeding, but certainly could include things like medical complications, myocardial infarctions, DVTs, different things that could happen, all secondary to the fact that you did a procedure, but certainly including medical complications. Complications are stressful, to say the least. One of the things that as you graduate and get out and work, you need to learn how to deal with them because they should be expected. They are going to happen. They're bound to happen. They're time consuming, both chair time and mentally taxing. They can be costly to both you and the patient. Patients, if they're dealing with a complication, has to miss work potentially. You're seeing them back multiple times, trying to manage potential complication depending on what type of complication it is. It can strain relationships, doctor-patient relationship, and this is where good communication is paramount. It can be a source of malpractice. This is why everybody needs malpractice insurance in order to practice in every province and certainly every state. It can compromise treatment plan. So certainly it can just slow down a treatment plan. Say you have a failed implant and it failed after a few months and you have to take it out, let it heal for a few more months, put another one in, let that one heal for another 4 months so it can slow it down. Or it could just compromise it altogether. Say you have an infection and too much bone resorption, and maybe they're not a candidate for an implant in a certain area, and you have to, maybe do a bridge or something like that. So it could change the course of your original treatment plan. As the saying goes, easiest way to manage a complication is to prevent it in the first place. This is mentioned multiple times to you, I'm sure, throughout your training. It was to me, and when you get on the other side, you realize how true that is. Just so many little things you can do to prevent problems, whether it's a technique thing to prevent a fracture of a tuberosity, deciding when to convert from a closed extraction to a surgical one to prevent a dental-alveolar fracture, whether it's prescribing post-op antibiotics for a poorly controlled diabetic to prevent that big post-op infection, instead of overlooking the past medical history and forgetting to. All about prevention. Most likely time you'll run into some type of complication is when performing surgery, and the most common surgery performed by yourselves will be exodontia. So why is it the most common source of complications in dentistry? Is it because you're just not any good at it coming out of dental school, lack of experience? Certainly every aspect of dentistry at the time of graduation you could use more experience in. There's no doubt about that, and you'll see very quickly in your own practice when you do graduate your proficiency, efficiency, knowledge, and that sixth sense that you develop around certain procedures really takes off. But it takes time in hundreds of cases to develop that, obviously, which you can only get so many of those cases while in dental school. Can we blame it on the patient? Is it always the patient's fault or past medical history? Other things like adequate radiographs and reviewing them carefully. Speaking to the prevention, was there a dilacerated root? And of course we knew it was going to fracture off around the nerve and we wouldn't be able to get the root tip. Should have referred it. Which speaks to preoperative planning, having a real good think about exactly how is this case going to go down. Step 1, 2, 3, 4, 5, knowing exactly what you're going to do, which instruments you need. which leads us to the other one, taking too much time. The biggest factor associated with post-op pain and swelling is length of case, which can speak to the case difficulty, but it could also speak to operator inefficiency and poor case selection, maybe taking off more than they can chew. So there certainly are motivations to be efficient from a patient outcome perspective. The best way to minimize complications, as we said, is prevent them, and exercising good case selection. Now, everybody is going to graduate with a different level of comfort with extractions, no different than you'll graduate with a different level of comfort with the classmate with respect to endodontics. And it's up to the individual to make a referral to a specialist based on their own skill level and what they feel is reasonable for them to tackle. So once again, the way to minimize complications is to do the following. Take a good medical history, review it, review the radiographs, come up with a plan, adhere to basic surgical principles, and go over a detailed consent with your patient. So when you're going over the patient's past medical history, be sure to also review their past surgical history, review their medications. Ideally, patients will bring their up-to-date list of medications with them, or actually bring in a bag of their actual medications so you can accurately document them. Review their allergies and the reaction that they had when they had their allergic reaction. Make sure we record their vitals as a baseline prior to any oral surgery appointment. And make sure that you go over the patient's functional capacity, which basically boils down to what they can do. And you'll hear a lot of us ask for that when you're presenting the patient is, what's their functional capacity? Because you've seen the patient and we haven't, we're sitting in the room. But it's important for you to ask them that and to make sure that they can tolerate the procedure that you're about to do. Here you can see an example of a not so great panorex, lopping off the right condyle, anterior mandible. Even though the patient doesn't have teeth, you certainly can get them in the focal trough. So this would be very reasonable to ask for a new x-ray in a scenario like this. Here we can appreciate some nastiness on this periapical film, but we need a orthopantomogram plus or minus a cone beam CT in a scenario like this to get a better sense of exactly what's going on, because we're only seeing part of the picture. This would not be adequate to proceed to surgery without additional better imaging. And here's an example of a reasonable panorex, where you can see all of the mandible and maxilla, the apices of all the teeth. This would be absolutely a reasonable radiograph to have on your patient prior to committing to performing an extraction. Preoperative plan. You should be able to look at any tooth that's about to come out and say, I'm going to do A, B, C, and D. Typically, the A is going to be your plan for local anesthesia, how much, which nerves, and then your extraction plan, which is often going to be your steps 1, 2, and 3. So your number 9 periosteal elevator, your 77R, and then the extraction forcep based on which tooth. But not always, depending on the adjacent teeth. Maybe you can't use a 77R. Maybe there's nothing to elevate off of. And then I say picking the appropriate extraction forcep, which we've reviewed in other lectures. And then also having, a backup plan. What happens if it cracks off at the gum line? You got to have your flap design planned and your surgical extraction plan. So for an upper 6, you may say, I'm going to raise a 3-corner flap with a vertical release, the distal aspect of the 7 into a sulcular incision. I'm going to segmentalize the roots, separating the mesial buccal from the distal buccal to the palatal. I'm going to use my 77R to elevate each of those roots out one at a time. So very reasonable to have that all planned out in your head. I certainly do, as does all the other surgeons. Prior to tackling anything, we know what plan A is, plan B, and plan C. This is one of those super important slides that you should have these things written down when you're in your oral surgery rotation. And anytime you're about to do an extraction, literally go through this list and say, let's comment on the location, the access, can the patient open? Is there any mobility of the tooth? How easy is this going to be? The condition of the surrounding bone. Is this a 92-year-old with an ankylosed 6? Or is it, 16-year-old with a partially erupted third molar in the maxilla that's going to pop right out? Number and anatomy of roots, the condition of the crown, is it severely undermined with caries, or is it intact? The health of the adjacent teeth is a big one. I do find a lot of people early days kind of have their blinders on a little bit just because they're focusing on the task at hand and won't appreciate the next door neighbor has a gigantic DO amalgam on it, so not allowing us to elevate against it, or a crown or something like that. So adjacent of the health of the adjacent teeth is super important to keep on your radar. Proximity of adjacent structures, things like the sinus, things like nerves, inferior alveolar nerve, obviously. Certainly want to be make that a talking point and beat us to the punch when you are presenting the patient. And of course, the patient's medical status. So you see a tooth like this, impacted tooth 3/8. Likely this can be probed with a dental probe, making it continuous with the oral cavity, making it more necessary to come out. So location, say posterior left mandible, access, depending on their opening, potentially difficult. Mobility, irrelevant. Surrounding bone, there's some reasonable follicular space and PDL space. In this case, so likely a younger patient. Number and anatomy of the roots. It looks like there's a mesial and a distal, which come together at the root tips. Condition of the crown, of course, is intact. In this case, it's an impacted horizontal 3/8. Health of the adjacent teeth, reasonable. Certainly a few spot welds on them there, a few small amalgams, but no crowns, no big DOs, so reasonable. Proximity of adjacent structures, the inferior alveolar nerve is right along the roots. Pretty normal for a tooth in this position. It's not crossing over. I'm quite happy with this, but certainly there. You need to be aware of it. The health history, of course, we're not 100% sure. Plan-wise, you do a 3-corner flap here. You would cut the crown off typically in 2 pieces and then take each root out one at a time. Rinse it out, put your flap back beginning with a corner, followed by a single stitch in your release. So while I wouldn't expect anybody to tackle the prior tooth in our oral surgery clinic, this could be a tooth like this premolar that could roll in. Patients booked in for extraction 1-5. So you would want to be able to go through this with those same talking points above and make sure we appreciate the significant dilaceration and have a plan for this. So a tooth like this, certainly I would start with my number 9, my 77R, followed by my 76S, and I would be wiggling this tooth, hoping to get some mobility, but it'd be very high likelihood of this root fracturing off, requiring a flap and bone removal with a number 8 round and a 701 root pick tip to get out that dilacerated portion of the root. Club-shaped roots, you always want to be on the lookout for these guys. These are killers. These are almost always surgical extractions where you have to raise the flap and then do bone removal down to the height of the curvature at the very least of the club or the hypercementosis area. Otherwise, it's not going to come. So these are always more difficult than they look and certainly require surgical removal. Once again, let's say one of the very important things to take a look for and stay out of trouble is looking at the health of the adjacent teeth. So say we were going to take out the 5 in this case. Looks like we're seeing the mental foramen immediately at the apex of this tooth, first of all. So you wouldn't want to be doing any aggressive curetting at the apex of this tooth. You certainly wouldn't want to be doing any elevation involving that 6. That behemoth restoration on there is just going to pop off. So your hand's really tight here, making this extraction more difficult than if the adjacent teeth were all normal health. So you'd likely have to go from periosteal immediately to your medial anterior and begin some nice rotational movements and a little bit of buccal lingual to wiggle this tooth out. Here's the 3/8 with some caries associated with it. First glance, it looks like sort of a lone standing mesioangular erupted 3/8. But on closer inspection, you can certainly appreciate some dilaceration down at the root tip. Now, you will see this relatively commonly, and after your inferior alveolar, lingual, and long buccal nerve blocks, you'll go around the tooth with your number 9 periosteal elevator. There's often not a whole lot to elevate because there's no adjacent tooth in direct contact with it. But a tooth like this, you sometimes can go with your 151 forcep. Give it some buccal lingual force to get it wiggling, and then you can actually do rotational movements up and out the back along the path and sort of along the curvature of that root, allowing it to all come out in one piece. And here is that exact tooth from the x-ray extracted. Better to be lucky than good. Certainly if the apex did crack off, you'd have to be prepared to go surgical, likely performing a flap and bone removal and using a root pick tip to get that last little bit out. But certainly good to know that certainly these guys can come out all in one piece if you identify that dilaceration before you begin your extraction, and instead of, say, using a cow horn in this tooth, there's no furcation, choosing the appropriate forcep to allow you to rotate that tooth up and out the back and getting it all to come in one piece. So once again, just speaking to the fact that prevention can be used here with good preoperative planning, preventing a surgical extraction, which of course is more likely to have complications. So some basic surgical principles to keep in mind. Anyone that's been in the oral surgery clinic and has requested help of the attending oral surgeon will often see us come in and change a whole lot of variables. So you'll see us reposition the patient to a better angulation, the back of the chair, often put it down a bit. We'll bring the light in. We'll often have our own headlight to get a better look at things, irrigate the field, suction it clear, so we can get a good look at what's going on. We'll put the bishops in a different place than maybe you had it. Potentially create a flap with appropriate soft tissue reflection to get a look at, see what's sort of taken place. Always, of course, recognizing asepsis. Super important not to be grabbing at things not in the surgical field. Never touch that sharps bin. That's covered in multiple patients' contaminants and should never be considered part of the surgical field. Achromatic handling of the tissues, super important. And one of the things that I see people sometimes do and not necessarily think about is start crushing tissues with their retractor. So with the bishops, instead of holding it against the bone or holding it in the vestibule and just towing it out, they'll be sort of pushing it against the soft tissue and crushing soft tissue with it, just because there's a lot of other things going on. And it's a stressful situation, but certainly it's one of those small but very important things that you can do to help with the patient's post-op recovery, is the achromatic handling of the tissues. Hemostasis, obviously super important. It can be tempting after you wiggle a tooth out. It's a bit oozy to say, yeah, bite on this, guys. But I was working with some students just the other day, and we were doing a surgical extraction, and we got into a little bleeder, and it was pumping pretty good, and it was certainly one of those ones I looked at. I was like, if we don't address this right now, it's going to be a long day for this patient. There's no way they're going to get good control over this with just biting on gauze. Eventually, it might spasm down. We put a little bone wax in, got good hemostasis right then and there. It was literally, quote unquote, bone dry, and then rinsed everything out and closed it up. So absolutely worthwhile from the hemostasis perspective to take your time, identify the source and address it and move on. The patient's going to have less pain, less swelling, less bruising, less likely to have infection if you do that. And debridement of the wound. Certainly if there's something to debride, go ahead. If there's no periapical granuloma or abscess or cyst, I wouldn't go down blindly, just aggressively scraping out all of your sockets. So selectively debride the sockets where there's something to debride, as opposed to creating problems by aggressively curating them all and potentially digging into nerves or creating oral enteral communications. Once again, prevention. So number 5, consent and complications. So certainly super important with extractions or any surgical procedure to have a written consent. The fact that they've signed it doesn't mean that you are off the hook. The most important thing is for the patient to be informed and educated. So certainly something you want to take time with and make sure you feel like your patient is informed. And if in doubt, get the patient to repeat back what you think you've told them. That's a great, very practical way to ensure that they've actually digested the information. You need to go over the usual potential complications, which are on the next slide. And at the end of the process, it is worthwhile having the patient sign the consent, because it just does highlight it that much more in their mind that process, and sort of signify that process has happened. So it's a little less forgettable for the patient. So all 11 things on this list would be fair game to have on your written consent. Some are more common than others, and certainly you would want to focus the conversation on the items that are potentially more likely to occur, like infection, dry socket, but certainly worthwhile mentioning all of the potential complications, including the uncommon and rare, because that's kind of the point of doing the consent, is that so the patient's informed of the likely post-op course, as well as all of the things that can potentially go wrong, no matter how rare they are. So my typical spiel in the informed consent process is to inform the patient that it's normal to have some pain, bleeding, bruising, and swelling for 2 to 3 days after the procedure, and after that it should be getting better. If it's getting worse at any point after post-op day 3, it could be infection or dry socket, and they want to give a call and come into the clinic so they can be assessed. Certainly it's possible to have damage to the adjacent teeth and soft tissues. Very rare to get a communication when you're dealing with the upper teeth between where the tooth used to be and the maxillary sinus. The way they know that is if they go home and take a drink of water or juice and it comes out their nose. That would be a sign that they've had this rare complication, and they need to get in to have that addressed so that we can close that communication over to prevent chronic sinus problems. When it comes to lower teeth, tell them anytime we take out any lower tooth, any mandibular tooth, they can get permanent numbness to the lip, chin, and side of tongue. I do educate them that the likelihood of this is low. When it comes to young healthy wisdom teeth, the likelihood is around 1% or less, but I certainly make sure that they've understood that this is a possibility. I will then give some mild reassurance, indicating that it's not a motor nerve. If it happened to them, the lip and chin would look normal, work normal, just wouldn't feel normal. So it's important that this isn't a sales pitch, not to convince the patient to do the procedure. It's to educate them. And if after an appropriate informed consent, the patient doesn't want to do it, the best thing is for them to walk away, and that's them exercising their autonomy. The likelihood of that happening is very low. The point is, it's not meant to sugarcoat it and dupe the patient into agreeing to do it. If they don't like the things on this list, that's their right to walk away at that point in time. and that's them exercising their autonomy. So soft tissue injuries, what usually causes these? Well, typically it's a little chip shot at a flap. So you haven't raised a big enough flap, or you've created the wrong kind. So you've done an envelope flap where you need the benefit of a 3 or a 4 cornered flap. You're putting too much tension on it. You get carried away with the extraction, and then don't realize that your retractor has torn the flap. So prevention is make an appropriate size flap, an appropriate type of flap. And management is, if it happens, you got to put everything back where it came from. So if it tears, you got to rinse it all out, and then put everything back with typically like a 4.0 chromic, got an FS2 needle, something relatively small, and take your time. There's a lot of motivation to prevent it from a patient pain and swelling outcome, infection risk, but a lot of motivation on your end as well, because it takes significant time to reconstruct these torn flaps. So it's worthwhile from everybody's perspective to make clean surgical flaps that are big enough so you can see, and then efficiently put things back where they came from instead of having to chase after tears. Other possible sources of soft tissue injury are with some of the other instruments that you're using for extracting teeth. Certainly the pointy end of the number 9 periosteal elevator. If you slip with that, it's got a cutting action. You could cause cuts. You could slip with your 77R and plunge into the floor of the mouth, under the tongue. You could reach too far down with your forceps and grab a big hunk of attached gingiva. All these things are possible and preventable. One of the great ways to prevent plunging with your 77R into the maxillary vestibule, or the palate, or the floor of the mouth, under the tongue, is to use a finger rest to prevent that plunging action, just like you see in this cartoon here. So what happens if you do make a puncture injury with something like a 77R? You certainly want to try and irrigate it out. Make sure you've not induced some hard tissue particles into the soft tissue. So give it a good wash out. If it's bigger than 2 or 3 millimeters, you might want to put a single interrupted dissolving suture in there, and potentially cover them with antibiotics. And anytime you have something like this, you want to see them back on follow-up. Make sure it's healed properly. It hasn't gotten infected. It hasn't caused a neuropraxia of the adjacent soft tissues. Abrasion injuries, typically with a surgical drill. These can be very nasty, absolutely worth preventing. It can be caused by an unprotected shank of a burr contacting the soft tissue, in conjunction with just not visualizing the soft tissue during the surgery. So this is why your patient needs to be open wide. If they can't, assist them with a side action mouth prop. Get your bishops in there and get your drill away from those soft tissues. Here you can see a lower lip that's about to get burned from the rotary action of a number 8 round, drilling against the maxillary teeth in a patient that isn't open wide enough and should have a bishop's retractor in there protecting those soft tissues. Things taking a turn for the better in this photo, where you can see a bishop's being used appropriately and to keep that shank of the burr well away from the soft tissues. All about prevention. What do you do if it happens? Certainly have to educate the patient, inform them as to what happened, cover them with typically just an antibiotic ointment like polysporin, and then follow up until things have healed. Other types of soft tissue injuries would include something like a wound dehiscence. So this is when your wound breaks down or falls apart, or where you did your incision comes apart. Can be caused by closing those soft tissues under tension, where they lack support underneath there. So say you raised the flap, you drilled away all the bone, and then you went to put things back only to realize that your releasing incision was over the area you removed all the bone from, so it doesn't have any support. An infection can certainly cause a premature breakdown or wound dehiscence as well. How to prevent it? So make sure you do flap design so that, say you're removing a cyst, you want your release to be not where you're about to uncover the cyst so that it will have support. Minimize tension of the flap. So say you're doing something like a bone graft and you're adding hard tissue to the area, you're going to want to make sure that your flap is passive. You've done periosteal releasing incisions, something like that, so you're not closing under tension. If you're closing under tension, the wound is almost going to definitely break down. Management, what do you do when these things happen? Well, it depends on the cause, but certainly if it was, say, a wound that histens over an area that maybe you enucleated a cyst from, you'd want to identify that, document it, inform the patient, follow up regularly until they've healed. Certainly consider antibiotics, lavage the area, keep it nice and clean, and consider reoperating to reoppose those tissues again. All right, complication number 2, root tips and tooth displacement. So the most commonly displaced teeth are the maxillary molars, where they can go into the sinus, also known as the antrum, or the infratemporal space, so right in behind the maxilla. Mandibular molar roots can be displaced into the sublingual or the submandibular space, just because that bone and the lingual aspect of those molars is quite thin. Even more rarely, they can be displaced into the inferior alveolar nerve canal. So when do we decide to chase after and remove root tips? So just to be clear, we almost always get our root tips out at the time of extraction. If we can see it, and it's safe to proceed with a 701 and a little root pick tip, we'll almost always get it. By the book, when does displaced root tip require removal? Well, absolutely if the tooth's infected, because if the root's still there, there's infected neurovascular bundle tissue in there, the infection is going to continue and get worse. You have to get it out. Like I said, if you can see it, it's typically safe from a risk-benefit perspective to tease it out. If it's a large piece, if it's greater than 3 millimeters, you should absolutely be getting that out of there. It's going to be poor form to leave that behind. It's going to be staring at you on the x-ray every time you take it. It's going to be in the way of a future dental implant. There's just no reason to really leave it unless the risks outweigh the benefits. Certainly if there's any apical pathology, you can't leave the root tip associated with that, or any chronic sinus disease, because you just don't know how much that root or that tooth was contributing to that. When could you consider leaving a root tip? So certainly if it's small, not infected, with no apical pathology, you can't see it, and it's close or contacting the inferior alveolar nerve, and you've concluded based on all of the above that removal would result in greater morbidity than leaving it in situ, then that's reasonable in that rare scenario to leave the root behind. Tooth or root displacement, what causes it? Typically 3rd and 4th year dental students. So excessive apical force. There should be 0 apical force when you're removing a root. Essentially, all your forces on root tips should be coronally directed. So there either has to be a little spot that you can contact that root tip with a root pick tip and tease it towards the opening of the socket. Or if there's not one, you make one with a 7-to-1 drill. At no point should there be any apical force when removing a root tip. Excessive force in any direction, so maxillary molar, excessive posterior force could pop that root out the back of the maxilla. Poorly controlled force, lack of visualization, so going in blind and doing blind sweeps, that's a big no-no. And lack of any soft tissue reflection, once again speaking at lack of visualization. And depending on the anatomy, some people, despite good technique and conscientious operator, will have like a really pneumatized sinus or really thin lingual bone in the mandibular molars, making it very likely to have displacement, but typically not. typically it's operator error, just sort of sloppy operating, and not having control and good visualization. It's sort of a daunting thing early days in your extraction. You're like, oh, hopefully it comes out in one piece, because if it cracks off, I just don't know what to do. And typically it is people kind of overthinking it a little bit. If you crack it off and there's a root there, you got to get it out. And the only way to get it out is to put some type of force on it to get it to come up through the hole where the tooth used to be. And you can't do that by poking on it with a pointy end of a number 9 periosteal elevator. That's going to displace it somewhere. You have to get something more fine, like a root pick tip. And if there's PDL space visible that you can sneak that in, or say it's a lower 6 and the distal root's out and the mesial root's still there, and you can see part of the mesial root sticking up, then you can contact that little bit of root with something, either root pick tip or a crier, and put a coronal force on said root tip to get it to come out. At the end of the day, you got to get some force on that root tip towards the opening where the crown used to be. It's as simple as that. And no force should be on it in an apical fashion like we're seeing with the big X through it. Such a basic concept, but it really is quite easy once it kind of clicks. I gotta touch this root with something to bring it towards myself. And you'll see people go in there and they'll just be putting in an instrument and just pushing it straight out the back of the socket. And it's like, no, that's never going to come. Forget that it's a patient. Forget that it's a root. Pretend it's a coffee table brain teaser. How to get peg out of wood. You would get something in there to tease it towards yourself. Simple as that. But for whatever reason, when it becomes a dental extraction, people get all confused and stressed out. And it really is very straightforward. It's a very delicate part of exodontia. And once you master it, your confidence level will go way up, because when you're extracting any tooth that if there is a root tip fracture, you're going to be fine once you know how to get them out. This, of course, shows why maxillary molars are highly at risk of displacement, just because basically they're surrounded by thin bone, and anterior superior is your maxillary sinus, and posterior is your infratemporal fossa. Once again, prevention, everything, just really controlled force and visualizing what you're doing. So when I'm taking out an upper third molar, if it's not popping right out in 2 seconds, then I'm asking my assistant to reach over with the suction so I can really keep an eye on that guy to make sure that it's not trying to go into the infratemporal fossa or sneak up into the sinus. So good visualization, controlled force, is going to make a big difference here. So what happens if it does go into the sinus? You would want to document it radiographically and send it to an oral surgeon. Then the oral surgeon can decide to either chase after it right then and there, versus leave it to let it kind of fibrose down for a period of time, at which point they could go in secondarily through like a Caldwell Luke approach, make a sinus window, and retrieve the roots at a second date. The same is true for the infratemporal space. You would certainly want to pack things up, call your local oral surgeon, inform them, at which point they can decide to go in and chase after it right then and there. Nowadays we would have the CBCT to give us a 3-dimensional position of the root, but sometimes they can be really tough to find in the fat pad in this location, in which case it might be more advantageous to let things sclerose down and secondarily go in at a later date. Certainly inform, educate the patient, and cover them with antibiotics for a week after to prevent infection. What do you do if it goes in the submandibular space? Obviously prevention, like we've been harping on. I've had a couple that are trying to go into the submandibular space. You can see the bone fracturing away, and what you can do is actually stick a finger along the lingual aspect of the posterior mandibular body and kind of milk the tooth back into the socket, and then you have to keep your finger there the whole time to support it while you finish your extraction. If this hasn't happened, and if it does go into the submandibular space, the same is true. Document, inform, educate, refer, and then the oral surgeon can either go after it then or at a delayed secondary date. All right, guys, that's it for today. Next date we'll pick up on aspiration and or swallowing of tooth material.